starting off with the shoulder exam, the first thing I'm going to look at is scapula stability. So what I typically look for is the medial border of the scapula, looking for winging, and that would be raising of the medial scapular border off of the thorax, the inferior angle tipping up, so winging or tipping. So those are the two primary things that I look for. The other thing that I want to look for is normal upward rotation of the scapula. And so the landmarks that I look for, again, are the medial border of the scapula and the inferior angle. And so what I want to do is I want to let the patient use his own strategy with raising his arm up over his head. And what I make sure I do is I do one arm at a time. Usually I like to start off with the uninvolved side first. And so for this case, if his right side is his more painful side, I'm gonna have him raise his left arm up over his head. Okay? And now what I wanna do is I wanna observe what happens with the scapula, particularly as it comes down. So keeping your arm straight, just lower it down nice and slow. And so now I wanna get an idea of what's happening with the scapula, whether or not we get winging from the medial border of the scapula or tipping from the inferior angle. So I can have him do that again, nice and slow, with the arm straight, right up over your head. And then again, and then slowly down. And so I can look at three possible strategies of raising the arm. So either raising the arm with the elbow straight up in front of you in the flexion. I can look at out to the side into abduction, or somewhere in between into scaption. And so I can look at raise up like in between, and looking at whether or not I see anything with the scapula. And so what I look at with the scapula assessment is just a yes/no assessment, whether or not there's winging, tipping, or whether or not the scapula actually rotates fully up. And I can do the same thing, step away from the wall a little bit. I'll do the same thing with the involved side. Nice and slow, raise it up, the elbow straight as you can, up over your head, and just like that, and then down nice and slow. And then looking at what's happening for those three specific movements of the scapula. So I'm also gonna look at whether or not the patient has full range of motion, or if he has any pain provocation with either one of these movements. And so what I can look at, again, flexion, abduction, or scaption strategy. The next thing I'm gonna go ahead and I'm gonna look at is whether or not, you can turn and face the camera now, whether or not he has any provocation with movements of the shoulder girdle itself. And so what I'm looking for now is pain provocation either over the AC joint or the SC joint. And so what I can do with this test is have him first shrug the shoulders up towards your ears, and then down, all the way down, is to press them as far as you can. And then I can have him keep his hands on his side, roll your shoulders forward, so protraction, and squeeze your shoulders back into retraction. Looking for whether or not any of these movements provoke symptoms, particularly at the SC joint or the AC joint, because these are shoulder girdle movements. Then I'll go ahead and move into my glenohumeral joint assessment. So the first thing that I want to look for is limits in passive range of motion. The capsular pattern of limitation for the glenohumeral joint is a 3-to-1 ratio of limitations, for external rotation being the most limited, followed by glenohumeral abduction, and then internal rotation. So these are the three passive range of motion measurements that I'm going to consider. And so what I'll do, starting again, this is his right side and the uninvolved side. I typically will start with the uninvolved side first. And so what I'm going to do is look at external rotation. What I try to do is I use my body to block his, keep his arm right into his side, and I'm going to rotate into external rotation. Take him all the way into the end range of motion, and then I can apply a overpressure. Okay? I'll do the same thing on the opposite side. Again, using my body to keep the arm right at the side, bring him all the way out into external rotation so I get to the end range of motion, try not to block him with my body, get him to the end range of motion, and then an overpressure. So that's glenohumeral abduction. The next thing I'm going to look at is glenohumeral abduction. And so what I'm going to do here is, for glenohumeral abduction, what I don't want to do is I don't want to let the scapula move. And so for this movement, I'm going to let him move into some external rotation, come all the way up, and there's the end of glenohumeral abduction range of motion. So I can compare that to the involved side, and what we should get with normal glenohumeral abduction is somewhere around 100 to 120 degrees of passive range of motion for glenohumeral joint. Next thing I'm going to look at is internal rotation. Let's turn around this way. I'll show this from the back. Looking at again, the right side is the uninvolved side, I'll come around, and what I wanna try to do is I wanna try to prevent him from going into too much extension as I internally rotate. So what I can do is I can rotate him internally here, and in some cases, if I can get the arm behind the back, I'll go that far. So that gives me an idea of how far I can go back into internal rotation. And I can give a little overpressure to get an idea. Can't really get his arm too far off his back, so that's as far as he can go in internal rotation. And I'll look at the same thing on the opposite side. So first seeing how far he can internally rotate, and then seeing if I can get the arm behind the back. And again, trying to maintain that elbow at a neutral position here, and then slight overpressure. There's my internal rotation. From there, that's my passive motion. The final thing that I can look at from a passive range of motion standpoint is how much motion can he get passively overhead. So I looked at active range of motion when I was assessing the scapula. The next thing I can do is see if he can get his arm all the way up overhead, and then give him a little overpressure here at the end. We're gonna come back to this again, but during the initial examination, I wanna definitely see whether or not I can passively get his arm up all the way as far as it can go, okay? The next thing I'm gonna go ahead and do is I'm gonna finish up with some resisted tests, some isometric resisted tests, and again, I'm gonna do both sides. I'm gonna start off with resisted shoulder abduction. I'm gonna bring my hand over to his opposite shoulder to stabilize him, and I'm gonna tell him to slowly build up his pressure and push out against my right arm. So push, 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 and then relax. If I don't stabilize on the opposite side, go ahead and push out against me, this is what's gonna happen. He tends to fall over to the opposite side, so I make sure I get my hand over here to stabilize him. I'll do the same thing on the opposite side. Go ahead and push out to the side, push, push, push. Slowly building up the pressure, making it a nice isometric contraction. Then I can come in and do the same thing for adduction. Now I'm gonna stabilize with my hand here on his hip. Go ahead and pull into the side and relax. And I can do the same thing on the left side. So stabilizing at the hip, pull into the side, pull, 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 good. Next thing I'm gonna look at is resisted external rotation. Try to make sure you keep your arm right into your side, and what you're gonna do is you're gonna turn out against me like that. Elbow into your side, and then slowly build up your pressure and push out against me. Push, 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 and relax. So it's really important, especially if you're a smaller therapist working with a larger patient, to make sure that you give them the cues of building up your pressure nice and slowly, push, 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 and that way I get a nice isometric contraction. Internal rotation, I'm gonna do the same thing. For this one, he's gonna turn in towards his stomach. Again, keeping your elbow into your side. I'm gonna stabilize over here on his hip, and go ahead and turn it, turn, turn, turn. Good. I'll come back around to the opposite side, stabilize, turn in, turn, turn. Good. The final resisted test that I'm gonna do are for the elbow flexion and elbow extension. So for extension, go ahead and slowly build up your pressure and push up. Good. Come back around. Slowly build up your pressure. Good. And then resisted elbow extension. Pushing down towards the floor. Good. And one more time over here. Push down. Good. Okay, so that's the basic examination for the shoulder.